From AI to the drug, we chase the life. Patient benefit is our strive. Our spirit strong, we fight disease. Steering the planet for health and peace. Welcome to CEO Talks with Alex Zhavoronkov.
Welcome to the CEO Talk. We have Stephen Quay today, the CEO of Atossa Therapeutics. We got to collaborate a while ago with Atossa and discovered multiple interesting insights into breast cancer and other diseases using frontier AI. Dr. Stephen Quay was instrumental in identifying additional uses of frontier cancer therapeutics for estrogen receptor positive metastatic breast cancers and way beyond. Stephen, why don't you introduce yourself and the company?
Well, great, Alex. It's great to be here. And yeah, I guess a little bit of my background for why I'm so excited to work with Insilico and the projects we've done together. I have an MD and a PhD from the University of Michigan, was a postdoc at night at MIT and a resident during the day at the Mass General, and then taught at Stanford for about a decade. And invented the gadolinium that's used in MRI imaging, and then now I'm company number 7 here. So one of my tabletop skills is sort of being a biophysicist. And so over the last couple of years working with Insilico, we've been able to do molecular modeling of how endoxifen, for example, docks with the estrogen receptor, how it interacts with a mutated receptor. Because one of the big challenges in estrogen-driven breast cancer, which is the most common, about 75% of women, is that unfortunately, after a couple of years of therapy where you're blocking estrogen binding to the receptor, they become resistant. And we now know the molecular basis of that resistance is mutations in the receptor binding site. And for the first time with the Insilico folks, we actually showed that there's an additional aspect to it where the receptor actually becomes constitutively turned on, even without estrogen. And that's because it undergoes an inactive-active equilibrium. And then we discovered that endoxifen actually stabilizes the inactive form, and therefore, even in constitutive cases, we're seeing strong activity. This is in cell lines, of course, not in patients yet, but it's really exciting.
Amazing. I've noticed that you have prevention kind of direction for metastatic breast cancer. Can you talk a little bit about that? And how big is this market in general? And also, how are you addressing it with the drug?
Yeah. So I think the important way to think about this is the way you just framed it, Alex. All epithelial cancers, so that's breast, lung, colon, prostate, go through kind of 4 stages. There's normal cells, and then the cells are growing too fast. It's called hyperplasia under the microscope. And then they begin to gather mutations, couple, 3, 4, 5 mutations, and then the hyperplasia becomes atypical. They sort of look funny under the microscope. You still see them maturing, and then they go to what's called carcinoma in situ, where they have the additional mutations that are about to make them become, true cancers. And that state of all of that is reversible. So it's driven by inflammation, it's driven by other aspects. We're not fully understanding all of them, but the first 6 or 8 mutations in the precancerous pathway are reversible. So what we know about breast cancer is that, for example, for genetic and environmental reasons, certain women have high density on their breasts. Their mammograms are more white than other mammograms. We know those women have a 7 to 8-fold increased risk of cancer 5 to 6 years from now. And we know that things like endoxifen can lower the density, and that should lead to a lowering in the incidence in the future. So we did a very well-designed trial at the Karolinska Institute in Sweden, where we had a sugar pill, we had a 1 milligram and a 2 milligram endoxifen dose, and we were able to lower the density after 6 months at a level that had been seen previously to prevent about 60% of cancers. So it's a long ways to go through the FDA process, but this prevention concept, and 10 million women in America have high density on their mammogram. Now, because of a new FDA mandate, they're being told in their report that, the good news is you don't have cancer. The bad news is you have this high density. Makes it hard to find cancers, and it's an increased risk. And we want to have a drug there to address that. So the physician can say, hey, look, this company has shown that with density reduction, you get a reduction in the incidence. So I'm very excited about this. As you can see, 1 woman a minute is being diagnosed with breast cancer. So during this interview, we're piling up women at the front end of cancer treatment, which is now currently cut, burn, and poison, as I call it, or surgery, radiation, and then some sort of additional therapy. So prevention is a big aspect of Atossa's work.
And what about beyond breast cancer? Would that approach work on other forms of cancer?
This drug primarily interacts with the estrogen receptor. Now, we have found in collaborations with the Mayo Clinic that at higher doses, a protein called PKC beta is also inhibited by this. The phosphorylation of that is also inhibited, which means the downstream AKT pathway is blocked. The nice thing about this is that pathway induces apoptosis. So most endocrine therapies cause the cells to stop dividing, but they don't necessarily kill the cells. But PKC beta and AKT are apoptotic.
And you've talked a little bit about the FDA position on this drug and prevention, and it's going to take a while. Are you looking at alternative markets and regions to open up trials?
We've gotten clearance from the FDA to do what's called Project Optimus dose optimization. It'll be 40 or 50 sites, and more than half will be outside the U.S. So Europe and Asia will be targets for this. We will do some sites in the U.S., but in certain aspects, these kinds of studies are better done outside the U.S. Project Optimus was a newly developed FDA mandate. Came out in August last year. It's a bit of an additional hurdle for oncology companies. In the past, you would do dose optimization in phase 2 and then go into phase 3, but your dose optimization was adequate, but not as robust as Project Optimus is designed to do. So this is really to find, there's a story in America called, the Goldilocks, where it's too low, it's too high, it's just right in the middle. So these dosing studies are designed to get the Goldilocks dose that will be best for patients, both from maximum efficacy, but then the best safety profile. Often that's, you're playing with those two with drugs. Although I have to say with Endoxifen, it's the first oncology drug I've ever dealt with that does not have a maximum tolerated dose. So it has a remarkably well understood and robust safety profile.
And how big is the market if you look at prevention and also treatment for metastatic breast cancer in terms of money-wise and also patient-wise? And how big is prevention compared to treatment?
Yeah, great question. And I'm going to focus on patient numbers that are currently taking drugs, and that the pricing, then you have to do pricing and then you have to do adoption. So we'll kind of stick with the medical science here. But so the prevention is broken up into 3 parts. The largest is about 700,000 women taking tamoxifen, which is a first generation drug, in what's called the adjuvant setting. So you have a woman, she has breast cancer diagnosis, she has her surgery, maybe she has radiation, maybe she has other, chemo, and then she is a stable, recovered breast cancer patient. But we know that she has a much higher rate of getting cancer, again, locally in that same breast, and now in the other breast as well. So there's a treatment space called adjuvant, which is 5 years after definitive surgery. And this is to prevent that local recurrence on the breast that had the cancer or the contralateral side. That's 700,000 women. Okay, next down the pyramid here is this, as we talked about, normal hyperplasia, atypical hyperplasia, and then cancer in situ, DCIS as it's called in the breast, atypia in the cervix. But DCIS is not cancer. It's often treated by surgical excision, but we know that even after surgery, these women have much higher rates of breast cancer because it's a field effect in the breast. And even though you take out the lesion from mammography, other parts of that field are showing changes. So those women will also get about 5 years of drug. That's about 200,000 women. And then the largest one is women at high risk of future breast cancer that have no lesions at all. So they don't have DCS or they don't have cancer. And out of the 39 million women who get mammograms, 10 million have high density. Now, obviously not all 10 million will get cancer, but the way I like to say it around is all women with cancer will go through that high density phase. So in the future, if you have high density by mammography, so your individual biology is leaning toward cancer, and you have a family history and you have some other criteria, that's going to be a time when you probably should take some prevention, either 6 or 12 months of dosing. Right now, about 120,000 women are taking a drug in that setting where they're high risk, don't have cancer. But so they're very large markets here. In the metastatic setting, it's probably on the order of 20 to 50,000 women per year in that setting. So if you can see prevention versus the treatment in metastatic, in terms of numbers, there's this big skewing toward prevention, and it's always better to prevent a disease rather than to have it. I started Atossa Therapeutics a long time ago because I wanted to bring what was the equivalent of the Pap smear to breast cancer. The Pap smear was invented in 1953 by George Papanicolaou, great big Greek name, and people shortened it to the Pap smear. But there were 115,000 cervical cancers that year, and we're now down to about 15,000. Not because the Pap smear found the cancers, they found the women on that 10-year path of hyperplasia and atypia to get the cancer, and then we could treat them during that period of time. I like to say that, unfortunately, getting breast cancer should be like, laying on a train track for 10 years and getting hit by a train because you didn't do something in those stages when it was reversible.
Thank you. And Endoxifen seems to have a very favorable safety and tolerability profile, so and very well annotated. What about combination potential? So if you were to go for prevention or treatment, what does it combine with, for the best outcome?
Yeah. So imagine you're me, the CEO here, and I've got Endoxifen, and I've got my patents, and I'm developing as monotherapy. But as Alex has now said here, many times women, their cancers change in a way that they really need something in the combination space. What I have 4,000 opportunities to think about combining another drug with Endoxifen. In the old days, you'd do some sort of manual operation in the laboratory, and you'd have test tubes and mice and all kinds of things. But what we did was we came to Insilico Medicine and we said, hey, let's look at the pathways that Endoxifen touches. When I speak about that, we're talking about something called the transcriptome, which is an amazing map of what a cell is doing. It's 20,000 different transcripts, as they're called, or different proteins. The blueprints for these proteins are 20,000 in total. They're changing on a minute-to-minute basis, and they're stimulated. So, for example, when you give estrogen to a cell line, 15 minutes later, 5,000 of those 20,000 transcripts change because the estrogen wasn't put in place. This is massively beyond the capacity of the human brain to manage, but it's well within the capacity of systems like Alex has developed at Insilico to look at what the transcript is doing under the influence of estrogen, look what Endoxifen does, and then look at what all 4,000 drugs do, and then come back to us, the humans, and say, hey, which drugs are synergizing the best with Endoxifen? We did that. We looked at all 4,000, in silico, because you can do that. You don't have test tubes and things, and came out with a class of drugs called the CDK4/6 inhibitors that were optimally positioned to combine molecularly with this drug. We're now in a clinical trial in San Francisco with that combination. Literally, from the time I got together with the Insilico folks and said, let's try this project of finding what the other partner was, 100 days later, I was giving it to patients. And to think about to be able to do that, years ago, we would have been 2 to 3 years into that process. And now we are recruiting patients very effectively in that trial. It's going very, very well. I have to tell you, I've done 30 clinical trials. So one of the hallmarks of a drug that's going to be successful is when you recruit patients in the trial ahead of schedule. Without going off the reservation in terms of numbers and things, because I'm a public company, I have said before, and I'm going to say here again, that trial of combining with Lilly's abemaciclib is going very well with respect to recruitment. And these are women who have pretty aggressive cancers, and so this combination, I think, gives them some hope that they can really return to a normal life with this cancer taken care of. Again, because at the higher doses we're doing, it's apoptotic. So our piece of the combination is killing the cells. The Abema CDK4/6 piece is killing the cells in a different way, and 1 + 1 is 3 in this case.
Thank you so much, and welcome to our CEO Talks. We're going to continue the series, and stay with us.